we all know the eye movements. Yeah, all of us are pretty comfortable with the eye movements. So we got rectus going outside, up and down, and obliques going opposite on the inside. There exists a functional relationship between some of these extra ocular muscles and muscles of the cervical spine. In particular, we have the medial rectus. And so if the medial rectus muscle is not being brought to threshold, whether it's the muscle itself, the associated cranial nerve, or the cranial nerve nuclei, maybe a physiologic lesion where that nucleus lives in the brainstem, regardless if that extraocular eye muscle, the medial rectus, is not being brought to threshold, then we're going to have a correction with head rotation, right? So if that medial rectus is not firing the threshold, our deviation is going to be an exotropic motion, right? And what's our head motion going to be to correct that? It's going to be this way. Yeah. Right? So what is happening in the cervical spine at that point? Say this is a P to A visual, and our right medial rectus is not being brought to threshold, and so we're going to be rotating this way. And when that happens, these right cervical rotator muscles are going to be what compensates as far as muscular tone. Alright, so we can palpate this as chiropractors and say, yeah, there's increased tone on the right. And we can bang away at it, we could adjust it, we could correct it, and then they'll probably come back the next week with the same thing going on because their eye deviation put that subluxation right back into place. Right, so we keep banging on this and banging on this, and we're not really doing this person any good until we fix the cause of the problem, right? Because as chiropractors, we fix the cause, not the effect, right? So we just got to know these systems. Okay. So what if this happens to a child, right? What if we have chronic increased tone on the right side of the neck and decreased tone on the left side of the neck? The increased tone is going to be decreasing gain, increasing sensitivity, increasing muscle tone reflexively. We're going to have more afferentation from the right side of the neck, right? Way more afferentation. And what is the primary driver of brain development? It's just this tonic afferentation from muscle spindles and mechanoreceptors, right? So if we have a massively increased tone on the right feeding the left brain, we're going to have an overdeveloped left brain and an underdeveloped right brain. All right, so imagine if this is going on chronically in a child during their brain developmental years. Do you think they're going to have developmental disorders, perhaps? All right. So that's what I want to do with that tangent. Next, I want to make sure we all have the eye position and head position down pretty pat before we move into the VORs. So you guys are pretty comfortable. Head goes down into the right, eyes go up into the left. Up into the left, eyes go down into the right. Where it gets complicated is with torsion. Basically, superior rectus and inferior oblique torsion the eye ipsilaterally, and so a lesion brings it the other way, and head tilt is also going to be ipsilateral. Right? So if we have a lesion superior rectus or the inferior oblique on the right, we're going to have head tilt to the right. If we have inferior rectus or superior oblique on the right, it's going to be contralateral. Okay, and that's really hard to say for you guys to hear me say and learn it from that. You just got to look at a chart, get it down. So basically, let's try to do one of these together. You guys can look at the chart to help you out. But if we have just a right rotation, what are we suspecting as far as extraocular eye muscles? If we're looking at the right eye, we have right head rotation. It means our eyes this way instead. This,
so lateral
this
rectus. Yeah, so lateral rectus is
and so we're correcting it by going this way. Alright, so that medial rectus is pulling it this way because the lateral rectus is not being brought to threshold. Okay, so it gets a little more complicated. Let's say we have head extension and right rotation. So then our eyes are down and to the left, meaning that those muscles pulling our eyes up and to the right are weak.
Inferior oblique.
They're down and in, which means they're weak up and to the right. So what's bringing my eye up in this way?
So that's superior.
Superior rectus, exactly. Or it could be the opposite eye.
Oh, right.
So it could be the
Then
inferior oblique.
inferior
or
is on the opposite.
Yeah, right. So then when we get roll, we can throw in that torsion stuff. I think if I try to get into that, I'm just going to bastardize it. So you guys look at that on your own and do whatever works for you as far as learning it. All right, so let's move into VORs. What's the purposes of the VOR? Basically, it's to stabilize the world, right? It activates the vestibular system. Upon activation of the vestibular system, you get an ocular response. And this is especially true for high velocity, low amplitude style movements, which is what the vestibular canals need in order to activate. So you guys remember the test we learned for testing VORs with the eye chart? Put an eye chart on the wall, have them read the lowest line that they can see, and while they're looking at it, try and do low amplitude, high velocity, no nose, and see if they can still read it. If it gets blurry, then they're having some breakdown in that system. What do you say they should be able to read it 1 to 2 lines up? 1 line up? So no worse than 1 line up. If they have a breakdown in that system, they're probably going to have a hell of a time reading any of it. Alright, so when you hear them talk about gain of the system, what they're saying is that head deviation should equal opposite eye deviation, right? And anything other than a 1-to-1 ratio is going to be an increased gain, decreased sensitivity, and breakdown in the overall system. Okay. So with that, we want to tie these extraocular eye weaknesses that I was talking about in with head position. But those are going to be more due to some sort of tropia, some sort of strabismus. But we could see the same presentation from a vestibular lesion. And so, do you guys have any idea how we differentiate vestibular-based head position presentation from extraocular eye muscle weakness? Basically, if it's an extraocular eye muscle lesion, it would affect one eye, right? If it's a vestibular-based lesion, we'd see both eyes compensating. So, I was thinking about it last night, and a good test for this would be the cover-uncover test, right? So you have the patient focus at a far distance. There's a couple ways to do this test, but the one I understand, have them focus, cover one eye at a time, and look for a correction of the eye that you can see when you cover one eye. Alright, and then cover the other one, see if there's a correction. They're staring at the same target the whole time. But if one of those eyes is tropic in any direction, you're going to see the correction when you cover the opposite eye, right? Because that eye is now going to become dominant because it's the only open eye. So you can do that. Let's see, you guys down with the vestibular canals and which eye motions they facilitate? So basically, I know they're canals, but the best way to think about them, for me, is to think about the anterior canals coming off your head kind of like this, the horizontal canals coming off your head like this, like a pencil sitting in your ear, and the posterior canals coming off your head like this, right? And anytime you orientate one of those to this direction, you're activating it essentially. So if I want to activate the right anterior canal, let's bring that thing pointing straight forward, right? So that'd be flexion, left rotation. And as a result, the eye movement would be up and to the right. So we'll be activating the right superior rectus and the left inferior oblique. Okay, now if I want to activate the left posterior canal, the extension, left rotation. right? Because I want to point that thing straight backwards. Is that helpful for you guys as a visual? Point that thing with the horizontal. And so the resultant head position would be extension, left rotation. And the eye position would be down and to the right. Right? Yeah. Inferior rectus on the left, or inferior oblique on the left, superior. Inferior rectus on the right. Okay. So that kind of lays the foundation for, you know, eye movements, head position, how it's related to the vestibular system. Just want to get that down because we're probably going to be expanding on it in modules and well, classroom hours to come. And next, since we have 12 minutes left, we should get into the center of mass, center of pressure stuff. You guys want to refresh on that? Okay. Steve, do you want to come be, or Sarah, when you guys want to come be my patient? Alright, so I'm doing this off memory, so if anyone wants to correct me, feel free. Alright, so to start, I'm going to start by finding pitch. No, I'm going to start by finding yaw, which is side-to-side rotation. So I'm going to have you close your eyes and look up and down as fast as you can 10 times. And then open your eyes neutral when you're done. Okay, so his eyes came from this direction, meaning that they were plastic in this direction. Okay, so the next step to this, okay, so if they're plastic to his left, what's the yaw? They're plastic left, and his yaw to the right. So you're going to see him with the right head rotation. Okay, so I want to go to the side of plasticity, and I'm going to have you look up and down at my fingers, just as fast as you can 10 times. Okay, that's good enough. So what you're looking for there is a breakdown in either the depressing or the elevating of the eyes. For him, he was strong going down, and then on elevation of the eyes, it was kind of bouncing around. You know, it wasn't actually hitting the, well, to me that represents fatigue, or some sort of breakdown in that, just weakness in those elevators. And so if he has weakness in his elevators, he's plastic down. If he's plastic down, then that probably means that
He thinks
he's pitch and extension, right? So now we got him yaw to the right, pitch up, or in extension. So that's where the test stops, right? Pitch and yaw. Okay, so if he perceives him, okay, if he's plastic down and he's plastic to the right. You're plastic, yeah. Okay, you're plastic to the left and plastic in extension. So
he thinks he's going
what's that? He's down here. So that's his center of pressure, his posterior.
The perceived center of pressure may be posterior.
Maybe posterior.
When you fall backwards or when you extend your head, it's going to push the eyes down. So you may think that that's
He thinks he's
possible.
back.
Okay. Yeah.
Yeah,
Or your head may be an extension.
yeah. He
Right.
thinks
And we
he's
could-
back into the.
We could double check this one of those center of pressure applications on the iPads or iPhones. You got any good clinical advices to correcting these?
Correcting?
Yeah,
Sure.
therapies.
Get a caption it and figure
Your
out where it really
CAPS,
is.
ENG, that would be the gold standard. But obviously we don't have one and we're going to afford one. Usually to correct for it, you're going to have to take into account the cerebellar activity as well as cortical activity and either do a microsaccade or pursuit or DOR to drive the eyes in the direction.
In the direction of those weak, in the
In the
direction
opposite
of the
direction
yaw.
of